All right. Our next presenter is someone that I just learned of recently through a colleague here in Washington State. And I had actually, I feel ashamed to admit this, no knowledge of the impressive body of work that she has done on behalf of patient and staff safety, and really working to provide the best possible care for kids with neurodevelopmental disorders so that they can not only receive adequate medical care, but adequate mental health care. So I'm happy to introduce Dr. Rena Sorensen and to turn this over to her.
Hello. Let's see if I can get this pulled up. Does it look okay? And everyone can hear me? Had all sorts of technical difficulties today. Okay. So thank you for that. I'm Renee Sorensen. I'm a psychologist and a co-director of our behavior safety team. So I'm considered the director of behavioral programming. And we run this team, but it's also a whole hospital-wide safety service that tries to track kids through our system. And so I'm going to give you a brief overview today and then try to leave time for questions. So we'll try to describe this system. And again, speaking to the choir here, we all know that we need systems to address these, and they're really, really challenging to build. And so we, like you, see these kids come through our hospital system. This is kind of focused on the neurodevelopmental population. However, we have it all who comes through our system constantly and get stuck in our psychiatric beds, in our hospital beds, in our medical beds, in our ED, just like you. And then overall, with our neurodevelopmental population specifically, although I'd say we see this with all behavioral health populations, there's just this huge shortage of services. And then when you have a neurodevelopmental condition on top of mental health worries, it gets even more compromised and more challenging with the communication barriers, the cost, the stigma, challenges for the right community services with the right supports. So just like you, we are in that same boat here in the Midwest. So back in about 2010, we had 3 patients who caused 40 staff injuries in 1 month. And that's what kind of ignited this process. And they were some pretty mild injuries and then with a few very, very significant injuries with that. So everyone was worried and dissatisfied and wanted to take care of kids, but were not sure how to do it. So we had a pretty significant meeting that was a little bit heated, but the identification was, and I was invited because I do severe behavior treatment for a living. Like that's what I was doing in the outpatient world for neurobehavioral populations. And, they wanted me to consult, but the conversation we had was that a consultation wasn't going to fix it. We needed truly a system of care. And so, what we decided to do is develop a formal committee to initially admire the problem and then tackle the problem. And so we did this through quality improvement work with the goal of decreasing both staff injury from aggressive patient interactions, and also to really ensure that these kids could access the care they needed. And we also didn't limit it to the neurobehavioral population, although that's who started it. We opened it to all behavioral health populations, and we don't care about diagnosis. So we help kids get diagnoses if they need them, but our team does not diagnose. We actually just serve the behavior straight out with what is needed. So a little bit about Cincinnati Children's. We're a very large, the 5th largest, we're in the top 5 of the largest U.S. children's hospitals. So we're a very big program. I've been here almost 24 years. And when I came, I think we had about 6,000 staff, and now we're like 18,000. So we've just grown exponentially over the years. And I'm not going to read all these numbers, but we're a very, very big hospital with multiple campuses. We have 2 inpatient programs, one at our Burnett campus, which you'll hear me talk about, and then a smaller one at our Liberty campus. Both have emergency rooms, periops, and inpatient facilities. Liberty is very much smaller than our Burnett campus, which is the big one. And then we have psychiatric inpatient at our College Hill campus. And this is actually an old building that just got ripped down this week. And we have a brand new building out there that houses a very large psychiatric program. So our psychiatric program, I feel blessed that we have this in our system. We have a small number of residential beds, but we actually have them. So it's amazing. And then we have inpatient units, and including one unit dedicated to the neurobehavioral population. We have partial hospitalization programs, 2 of those, and then outpatient care as well, and a bridge clinic that helps us get some of our crisis patients out of the ED, but in a bridge appointment to bridge them until their next outpatient care can catch back up with them. And so we keep trying to build this bigger and stronger because we know we need broad-based care to deal with the current epidemic we have of behavioral health concerns across our programs. And then I'll call out our emergency department a little bit. Again, we have one of the busiest pediatric emergency departments. Burnett campus has the level 1 pediatric trauma center. We have a smaller ED at Liberty, but both of those EDs provide psychiatric assessments, and they have designated spaces with behavioral support staff to support kids in those assessments and while waiting for placements. And I mean psychiatric placement or safety planned home or connecting them with partial hospitalizations. We do send kids to other locations around who have beds. So we're always looking for the open bed that might include our system as well as others. And then at the Burnett campus, we actually had just recently redesigned our emergency room, and it has a behavioral health area, which has very safely designed rooms that you can provide both some that don't have the medical components to them, but a couple that do, that are behind garage doors so that they can be converted easily to medical if we have a patient who needs the medical care but has high behavioral risk. And any placement patients we have, so we will hold children in our ED for psychiatric overflow. The highest risk will stay in the ED waiting for an open bed. Lower risk patients may be admitted to a medical bed for psychiatric overflow, which is where my team picks up with them. And then the placement patients, if they're psychiatrically cleared, they'll go into our medical center, and our behavioral safety team will pick them up. And if they need psychiatric stabilization prior to a placement, then they would go to psychiatry, and they don't necessarily move to the medical center after that. Psychiatry usually works on their placement from there. So our new building has a more organized length of stay program for kids who are otherwise psychiatrically now cleared, but are waiting for placement. So we have kind of developed a broad-based way to kind of manage this flow through our system over the years. So this team that I'm going to speak to more specifically we call it the behavior safety team. And our goal is really just to get kids the care they need safe for them and safe for us. We do want to make sure we have access to equitable care across our populations. And so the criteria is very simple. If they have behavioral risk of aggression, self-injury, property destruction, disruptive behavior, and that can include severe verbal aggression. We don't necessarily pick up every child who swears, but if they are threatening staff, that can be really hard when you're providing care. And then, or if their behaviors prevent them from accessing care. So kids who won't come into the building, they shut down once they're here, they won't interact at all with staff. And so it's really hard to get them to do care. We will pick all of those kids up and support them. We've had a lot of growth over the years. I'm not going to go into detail in this, but we started with just a psychologist, which was me, added child life kind of devoted time. We worked in tandem, and then we just continued to grow. So our behavioral health consultant role was a master's prepared person, and it is now a behavior analyst. We've just converted those over. And then we have these behavioral health facilitators. That role is they are bachelor's and master's prepared folks who have experience. Most of them have come from being bedside staff. Then we added managers and converted up to director. And our current program, this looks a little smaller, but we have 2 co-directors. So myself and our program director, a care coordinator, child life specialist, and that's at our Burnett campus. And then we have 2 behavior analysts, 1 at each location. So we are located at Burnett and Liberty, the 2 inpatient, periop, and ED locations. And then we have 22 behavioral health facilitators across the 2 sites. Liberty gets less of the group, but they're 24/7. We just went to 24/7 this year for Liberty. And then spread, we have about 2 per shift, and we're going up to 3 per shift at the Burnett campus. And our primary focus here is inpatient 24/7, but we also run a subset of ambulatory care, which I'll go over. And then just to note, early on in this process, we started converting our bedside patient care attendants, PCAs, to a subset of them to behavioral health specialists who are one-to-one staff who have a little bit more, their bachelor's level prepared with a little bit more training. We train them in therapeutic crisis intervention and some strategies around different diagnoses, autism, neurodevelopmental conditions, and they are the people who staff the patients one-to-one at bedside if they need it. So we only staff if their parents can't quite manage it all, or if they don't have parents at bedside. So the highest risk staff get the most competent, or the highest risk patient gets the most competent staff. And then we assign that very carefully across our shifts. Today we are staffing 15 patients, but we have 21 on our list. And that is at the Burnett campus, and we have like 2 at Liberty. And so we have 9 behavioral health staff per shift. So we still cover with PCAs who also have some safety training as well. So we serve quite a robust population. When we started this, it was about 1 to 3 patients a week, and now we average 15 a day, and we keep growing. So like over the last couple months, we've had 20 and plus several times a month, like kind of the majority. So we're really popping right now. So we have 2 kind of models. Our inpatient model was our bread and butter that started us. We proactively identify patients. They are screened at admission by the nurses who do a screening. If any of those buckets pop with that screening, they are referred to us. And then anybody, the docs and nurses can also do a consult order anytime during admission if something comes up as well. And then we will do a full interview and risk assessment for those patients, determine if they need us and our support. Sometimes if we think they can get by with child life, we will not pick them up. So we don't pick up every patient, but we try to guide them to the right services. And then we create safety plans and behavior management plans. And then we actively support procedures and run a BRT crisis response team as well. And then in ambulatory, we follow those children through our system. The charts are flagged. We know where everybody's going. We have what I call the air traffic controller, which is our intake coordinator who watches these kids through our system. And then we try to make sure they're going to the right location to get the right level of care. So we do restrict some of our kids down to our big campus where we have the most support. And then we try to get them tolerated care so that they can go back out to their neighborhood locations and get support there. So we'll be present when positive. And then we work collaboratively across our child life teams to support these. We've built a lot of systems with this. So I'm just going to do high level. One is just identifying and communicating with patients with risk. So we do these risk screens, build the safety plans. We flag the patient chart if it warrants it. And again, we try to write them in a very behavior plan kind of very matter-of-fact way, and work with our staff to not read those or use those in a stigmatizing way. We're not trying to keep kids out of care. We're trying to help support staff in providing safe care and keeping themselves safe while they're providing care. So we developed all those kind of systems for referral. We have the one-to-one staffing model, again, if needed, but they are behaviorally trained, and we have a competency leveling that we do to help make sure we're assigning them appropriately. We do rank our patients each shift for acuity so that we can do those assignments. We've worked on our environmental safety checklists that we do for the kids who need those. Those are patients in overflow, definitely get those. And then any child who would come in and have a suicide or cutting risk, we typically will implement the environmental safety checklist. We have developed a behavior response team. So it was modeled after a medical response team. It's a 24/7 code response. BST leads that, but it brings the medical bedside, nursing, et cetera, to huddle together. And we can do a huddle, or we can do the complete escalation where we're in the room trying to de-escalate that situation. We have put behavioral PPE across our hospital. So just like you can find gowns and gloves on every medical unit, you can also find Kevlar sleeves and gloves on every unit. We ask our staff to put those on prior to going in the room with any patient who's had identified risk if they're going to be providing close contact care. So we try to mimic the infection control PPE for those things. And then we do have higher level PPE. So we have a young man in our system right now who's waiting for psychiatric overflow. He has autism and excitatory catatonia. He's very disruptive because he's having trouble utilizing his brain in an effective way. And so we have higher level PPE. Staff were wearing what we call bat wings, which are Kevlar that go all the way up, chest protectors and helmets. When he was escalated, we would put helmets on as well so that staff don't get concussions while they're trying to physically manage and keep him safe and get things under control. And then they can pop their helmets back off, but they keep the chest protectors on all the time because he was kicking and hitting. So we have a lot of work on those things, putting them in the right place, policy development, to make sure those are well managed and maintained. And then we are constantly in a learning system where we do injury debriefs and daily huddles. We work on event reviews and are constantly updating our policy work to keep our system in a learning mode. So we are a proactive service. A lot of people work on developing the behavior response teams first, and that's fine. Our approach was to do identification and try to prevent and mitigate risk before we would just do the escalation and emergency teams. So we often do find that our patients can actually improve and we can fade out of services or they have less service need over time. We really focus on teaching kids to tolerate their care. And even when they come in for psychiatric care, if they can come in and get that over and over again, we might see them in overflow several times. And again, we just pull the behavior plan that was developed on their inpatient psychiatric admission and implement it and get them started in their crisis stabilization while they're in our medical overflow. And we keep going. If they would happen to come in medically, we have those behavior plans as well that we will implement to try to keep them as steady as we can. So we try to just be a really one unified system as much as we can. And then our team teaches and models appropriate care for our nurses and docs who may not have the experience with the population. And we see a lot of improvement from that. I really feel like COVID hit us hard when we had lots of staff turnover and we kind of had to start over again and rebuild, but we're definitely rebuilding, and we're seeing a lot of folks really put in that trauma-informed care and being able to identify kids as kids in distress versus this child's out to get me kind of approach. So we built a lot of different staff education into our system. Overall, we use a therapeutic crisis intervention TCI certification for all behavioral health staff across psychiatry, in our EDs and in our medical center that are focused on this population. And I'm not saying that TCI is the end all be all for hospitals. I think every system has to look at what's right for them. This is the one we chose for us. It's an initial 4 days and then 2 times a year maintenance. So it's a huge lift to do this, but it is great to have one unified system so that when we speak the same language when we're responding to a crisis, especially. So that has been super helpful. And then we developed our own offshoot of what we call CCHMC safety training, which is in 4 to 8 hours. And it is for folks who will not need to do physical management, but really teaches broad-based staff in de-escalation, personal safety, and trauma-informed care to help them approach all patients in a way. And if they trip a trigger, they can quickly try to de-escalate that before we move into a higher escalation and keep themselves safe. And that is a newer launch in the last couple of years. So we're still trying to get a lot of people through it. And not everybody will be trained in that, but we are trying to get our frontline staff pretty well trained as much as possible, and our emergency room folks. And then our nurses and residents get a introduction to our team and kind of the broad safety system in their orientations. And then we help with the annual safety modules that go hospital wide to kind of build these components into ongoing to try to keep people up. And in that we embed our neurobehavioral kind of educations. We talked a little bit about a behavioral PPE, just some pictures. We've done a lot of work on developing door signs, just like you would with infection control. And we're moving to the point that they're actually going to be on the door, just like infection control, because we've done all of our testing and it's been adopted and accepted. And so those will just be door signs that we turn. We found that the BPPE required doesn't seem to cause any stigma for families because most people, if you don't know what behavioral work is, you don't know what that is. And so it doesn't really draw any attention. And then our staff call one number when they are injured, and it's really to report any safety situation. So it's the same for a staff injury. And they are asked what PPE they were wearing or if they were wearing PPE, and that just helps feed our system. If people are following our policies and doing what they're supposed to do, we don't really, they're usually in trouble with that. It's truly just education, and we teach them back and keep trying to get our staff to be more compliant with the policy. And then again, we have a lot of regular training in the safety work that's built into our system. And then we really have had to focus a lot on changing the cultural mindset about behavioral health populations. So we do a lot of work on this, and we find with new folks, or if they have a really young team, we might even have to go to the unit and do some specific training, but we do pretty good at just referring to kids as children in distress who need support rather than problem. And then our other big philosophy is, instead of focusing on the child's behavior, we focus on our own. And so how do we help support kids and change our behaviors so that we can help the child actually improve their behavior? So lots of work on that. We do a lot of information gathering, so that's built into our system. We do very detailed interviews to gather information. We have a risk assessment we do. It's based on the initial behavior assessment, which is, there's a couple articles published on that. And it's available if anybody would want it. That's our risk screen. And then we're putting basically all of this information we have into a document in Epic, and then we're trying to update it. And it's also part of our flag. So we use Epic, and we have a patient chart advisory that flies so that you open the flag, you're going to see this on the right-handed side. It's all in a systematic standardized format. So you're going to get a basic of the child, what's their communication, what's their triggers, what PPE should you wear, some basics of strategies. It's not an end all be all, but it really gives the basics of the most important thing to do. Consultation, and this will say if they have an adaptive care plan or if they need BST support. It will say if they should be, appointments should be at Burnett campus, or, might say they need BST support for needle-based care. And then it has how to reach us and then a risk level. So that's a big communication across our system. For our BRT response, we have two options. It's one number. You call the BRT. You tell them you want a huddle or a stat. Our huddle is our team will arrive in 15 minutes. And this is when we are concerned that there might be an escalation and we don't have a good enough mitigation plan, or people are feeling uncomfortable. And we will work with them to develop a better plan. But it brings our team, charge nurse, bedside nurse, physician, MPS, which is our manager of patient services, protective services, and then we'll bring the parents, or if there's a bedside staff, all together. This is also in our ambulatory, so there may not be a charge nurse or a bedside RN, but we'll just use the clinic staff depending on what is available, and we'll problem solve how to mitigate the situation. And then if it's a stat, that's an active escalation, and so we do an immediate arrival. Usually BST is in right with the patient, doing the de-escalation, occasionally restrain if we need it. And then after that, we will debrief and get the mitigation plan going. So we'll get everybody safe and then do placement or planning to try to prevent that. Our work on stuck patients. So when we get patients who are boarded or placement here for long-term, what we found is that when they have really good behavior management plans, it really helps placement. So people are much more likely to take children back into foster care, into group homes, into all sorts of things if they have a really nice structure and something we're working on that they can try to replicate. So we work hard to do that, working on the whole child and trying to make sure that we're incorporating school. If they need therapies, we're trying to get those going and providing the structure and activity they need. Kids can destabilize pretty quickly if they're stuck in one room in our medical center. So psychiatry is better for that because they have at least the milieu and playgrounds. We do have playgrounds at our medical center too, but it's a little harder to get to them. They're not as easy to access as they are in psychiatry. So, but we try to actually get them going and get them out of the room and make sure we're kind of looking holistically as much as we can. It's never perfect, but we've come a long way in how we do this. And then we try to just meet with this small team periodically, at least, to make sure we're on the same page and kind of moving in the same direction. And then for true placement, we have really gotten pretty good at this, where we start a weekly meeting with the stakeholders in the community. So Child Protective Services, if there's any agencies involved, the family, if they're involved, whoever the folks are. The first meeting is usually the longest, where we have to meet everybody and go through kind of what our goals are and what we're trying to accomplish, what the needs are for this child and family. And then each week after that, we just continue with usually a 30-minute meeting. We update on how is the child medically, how is the child behaviorally, what's going on, what are we trying to do? And then the other stakeholders are identifying what they're working on, what are the placements, what's going on. And we find that stakeholders really relax when kids are in the hospital because they're safe. And so this helps us keep kind of the pressure up that this child is medically cleared. It's not a great place to be in the hospital. We need to keep them moving, we need to keep finding, looking for those placements. And when you have to report that out every week, we find that they actually get to it much faster, and we get a lot of problem solving going on. And so we're typically able to place kids much more quickly than we used to be able to do. So that's been a really big help for getting placements going. We use continuous improvement and do a lot of data collection. So we're constantly looking at our staff injuries. Today, we are up to 219 days without an OSHA recordable injury in our medical inpatient units, which is really good because we've been very acute and very busy. And then every year we analyze our injuries by role, by type. And we're always looking at, for the patients who referred, how many injure and we're able and how many don't injure. So over the years, we've been able to keep up right around that 90% level of patients who are referred to us who do not cause injuries, which is where we're at. And then here are some resources that I sent before. I'll just call them out a little bit. So the Solutions for Patient Safety started in Ohio. It's now a national program for pediatric hospitals utilizing QI work. And they initially focused on infections, CLABSIs, CLAUDIs, et cetera. And they just safety overall. And then they have expanded to employee and staff safety. And with that, we've worked on patient behavioral events as part of that cohort. And so you can join Solutions for Patient Safety, and then there's lots of different things that go on throughout the year. There's learning sessions twice a year that always address these issues, and it's a lot of networking with hospitals trying to build these types of systems. So it's been really helpful to collaborate across programs. And then if you're familiar with the Project ECHO model, which is trying to take experts and get information, instead of bringing people to the experts, it's actually using the virtual world to bring the expertise out to people. And we have a behavior solutions and hospitals ECHO, which is targeted at autism, but it's really can work for any behavioral health kind of situation where, again, we're having kids stuck in hospitals or having to be in the hospital to get care that they don't always cooperate with. So we're working, that's more of a case-based and presentation-based approach to helping hospitals solve those problems, and that's ongoing. So you can join those cohorts whenever they start. And again, it's a free resource, and you can also get CEUs, so it's kind of a nice thing. And then we did publish our BRT response, so that's in pediatrics. So that was kind of fast and furious, but if you have any questions.
Well, let me just say, just like the first time we had a conversation, wow. There is a question in chat. The question is, do your debriefings also include discussing the behavioral events with the patient as well, if they're able to participate?
So we don't do that in a big team, but we will do that more one-on-one. Yes. So if we can, and we call that, so part of TCI is to actually do a debrief once the child is calm, and we kind of repair with them and get them going. And so we absolutely will, if the child can do it.
All right, we do have time for questions. Thank you for building into your presentation. Questions for Dr. Sorensen?
I have one. I'm not sure, Dr. Sorensen, if you've been able to listen in during the day to some of the other presentations. I'm seeing some sort of model efforts that I think about synthesizing some of these components, across systems of care, the tribal stuff, the school stuff, what Oregon's up to. Do you see, if you've had the chance to listen to any of the others, where does kind of your model fit into integrating into some of these other national best practices? And I'm also wondering, we're going to hear from Dr. Lucas Zulu a little bit later on some of the ED-based interventions that aren't necessarily designed with kids on the spectrum in mind. Are they translatable to that population? That's what I'm wondering about.
All good questions. I did not join today. If you'll see me, I'm in a t-shirt and scrubs because I've been running around because we're really acute right now. So I was not able to join. So I can't answer that, but I think just from me being in Solutions for Patient Safety and doing that work over the last, it's been like almost 4 years now that I've been in there. the idea sharing across systems is tremendous, you know, and that's what helps build us, I think, continue to build us. So I would bet that what you guys are doing out here is, you're going to find that same thing, that you can pull components. And then the other thing we see is there's some foundational things that probably every system needs, but the level of what they need each type really depends on their system and the population they're seeing. So we tend to see way more kids with risk than a lot of other hospitals do, so they don't need to build to our level. And so, you know, I think it's just being open to those kind of concepts. As for the neuro behavioral population, I think it's a spectrum, you know, of kids. And so some of those kids can take some of the interventions for a typical population. And if you make them a little bit more concrete, or can adapt them and kind of learn how that child learns a little bit better and adapt them a little bit, they can be wonderful. But there's a subset that need a completely different approach. And I think they often get missed. And that's kind of what our team specializes in. Is we have pediatric psychologists, and I'm a psychologist, throughout our system doing consult liaison work. And they really take the kids who can do good cognitive behavior therapy, as long as they're not too acutely aggressive. If they're acutely aggressive, we both serve, and they'll do the cognitive behavior therapy part. And we do the kind of the safety system around staff and support of other care. So, so I do think the neurobehavioral approach, especially the more challenging end of that spectrum, need a very different approach.
I think we have another question from Dr. Sakata at the Northwest Regional Healthcare Response Network in Washington.
You're muted, Vicky, if you're trying to speak. There you go.
All right. Thanks a lot. Thanks a lot. And Dr. Sorensen, that is an amazing presentation. Kudos to you and all the work that you've done over the many years. That's as a peds ER doctor and adult ER doctor, both, that is incredible. So kudos to you. I guess my question is, now I also work here for the Healthcare Coalition, which is, you know, regional here in the state of Washington. I'm assuming that where you're positioned in Cincinnati, you're obviously a regional referral center. So would you say a majority of the patients that you're taking care of, are they referred from outside facilities, or are you helping outside facilities sort of improve their programs as well? How does this work in Cincinnati regionally when you're dealing with so many children? You know, as we were all saying in the beginning of these sessions, how it's just, you know, it's a global problem, and we have kids that are stuck in ERs all over the state. So I'm assuming it's the same way there, or are you just pretty much kind of taking them in at Cincinnati Children's, and you're able to manage them there? Just wondered how it was happening throughout the state there.
All of that, really. So in Ohio, we're a little bit lucky in that Nationwide Children's Hospital has a behavioral health pavilion, and they have a neurobehavioral unit as well, and a pretty large inpatient program. Dayton Children's has an inpatient program. They don't have a neurobehavioral program. So we tend to take from a broader space for the neurobehavioral population into our psychiatric center. However, we really kind of run that we mostly serve our local region first. So sometimes we have to close down to outside referrals if we're really backed up, because we don't want them just waiting and waiting and waiting. We can't get them in. And so really kind of pushing other folks. And there are some options in some of the other facilities too. I mean, so we have quite a few places around that do have options for all sorts of patients. But we're the biggest and probably the most comprehensive. And so we do tend to get the hardest of the hard. If they've failed other places, they'll tend to come into us. We're seeing a ton of catatonia and a lot of catatonia in our neurobehavioral populations. And so we have the access to ECT at UC. And so if they're treatment refractory for catatonia, which can be life-threatening, but Nationwide now has developed that as well. So that in Columbus, so that's helpful that we have two, at least in the state, because they will come from a very large, you know, families will just drive a long distance to our ED to get in. And so we do find them to just, if they couldn't get in because we closed to referrals, they just show up in our ED and then they're in. And so they find their ways, and we don't blame them. I mean, we just take them when they come, and then we try to do the best we can. But again, I'm trying to find them the right care for the long haul, because they do have to go back to their communities at some point. So we see everything. And because we're a top ranked children's hospital, we always do get referrals from all over the country. And sometimes the families will say, we come here because we get the behavioral care in addition to the medical care. So we do draw a very large range from all over the country, coming in specifically for certain things. And for some of our specialties for medical, they will bring them in. They have pipelines to bring them in, and they will do that as a specialty service. And then for our psychiatric, it's often more closed regionally, but we end up, again, they'll come in different ways. Or if we are not as full, we will open it to those populations and take as many as we can. So but it ebbs and flows, and it's kind of a constant adjustment of what can our system handle right now.
As a follow-up question, Tona, can I ask a follow-up question, Dr. Moore? Okay. As a follow-up question, when there are multiple patients obviously in need of services, is there any sort of coordination that's trying to help, say Dayton and you and other facilities in the state that help to coordinate or triage those patients? Or is it, just it comes as it comes kind of thing?
There's several things being built. So we have we have a program called Health Find and then Ohio Rise. So there are two programs that are kind of trying to case manage and look across our state. It's a state funded, state coordinated. It's still kind of a little bit early in its infancy. And I know that we're getting kids moved to other psychiatric facilities more quickly than we used to, for sure. And it's through that entity, which is, I think, like some of what I was seeing was they're trying to monitor where are open beds and how do we all share this load and try to get kids in and give them care. And so that is improving dramatically right now, but it's, it's kind of we're in our infancy with getting that done, but it's definitely made an impact for sure. So.
Great. Thank you.
You're welcome.
So a kudo for implementing behavioral PPE, just like infectious disease PPE for you. And then a question: what are your solutions for collective families pressuring schools to remove children with perceived potential violence? The targeted students have been determined to not pose a risk based on threat assessment.
So schools trying to remove kids?
I think families pressuring the school remove the kids is what I read. Cynthia, if you want to unmute and clarify.
I'd love to hear more about like the families of the child or families of another child.
Hi, this is Cynthia. Can you hear me?
Yeah.
So I'm talking about schools. There are a lot of children that are targeted by bullying because they're perceived as a threat by families collectively, especially with all the violence in schools that we hear of and active shooters. So they're kind of put in that box when they're really access and functional needs, or they've experienced trauma. So I feel like this question needs to be considered. How do we address these concerns, these elevated concerns by families? This may be better answered by another panelist, but I thought I'd pose the question. Thank you.
Yeah, it's probably better answered by another panelist because I'm stuck in inpatient. But we have also, we've put services in schools as part of our solution. I'm trying to go back to my psych slide. Trying to see if it's in here. It was in one of my psychiatric slides, but I don't know if it made this one. But we actually, school-based programs. So collaborate directly with 58 community schools and 81 team members to extend mental health services to schools. So we would pick that up in that group if there was kids being targeted in that way, to kind of work on that directly. But I don't have any specific solutions for you other than we have extended what we recognize in our numbers is that our lowest time for psychiatric admission is summer. And it's, the minute school starts, we're slammed. We get a little bit of reprieve kind of in December. I always call it, it's when Elf on the Shelf comes out. and Christmas gifts are threatened. And then we go back into it, and the heart of winter is our worst time. So as we're hitting those long winter months into spring, we just are just so inundated. So we, what we knew is we had to get into the school systems and start helping there where it's so stressful for kids. So they've started those programs. So I think that's where they probably have better answers than I do in terms of the specific interventions they're doing. But I think you bring up a very important issue. I have one child left. She's a senior in high school, and she's my last one in public school. And I am regularly, and we're in a great district, I'm regularly appalled at the level of stress that kids are put under in school. Like, I work actively to be like, that is ridiculous. We are not worried about that. Do you know what I mean? Like, because the kids it's amazing what there is put on them. And in a good district that just doesn't need to be there. So
just following up on that, it sounds like schools and parent groups in particular, maybe parent groups even more, but schools to have it as part of their educational focus with parents, information about, like you say, this is a child in distress. This is not this child may not be a threat. This is a child, the behaviors reflect the child in distress. Right. Or the adults have to be calm, even if the kids can't be calm. Right. I think those educational materials probably would be useful. I don't know if there are any of them out there, but it seems like, attending the PTA meeting with the topic being, here are things that you should know about kids on the autism spectrum.
Right.
Might be useful.
Great. Our my local district has again, it's a very strong school district, good academic record, and we've been inundated with suicide. And so there's folks who are like academics, and I think a lot of the parents are going wellness. So I think all those supports so we've had advocacy programs built with families and teachers to kind of help support and push the school district in that direction of supporting students rather than trying to push them out, but truly supporting in a broad spectrum. And then, yes, identifying kids who may be unsafe in schools. That's important, but we can't just label everybody as unsafe and kick them out. Yeah. So, yeah.
Time for maybe one last question. Seeing none, hearing none. Thank you so much, Dr. Sorensen. Has been
welcome.
Really, really useful. Grateful for your resources, grateful for your slides.
I put my email at the end.
Thank you. And we did talk about you being willing to have people call and consult with you. So thank you for that.
I am. And if I ignore your email, just email me again. It usually just means I'm on the floor and it got busy. So, because we are pretty all hands on deck right now, we're actually hiring, and hopefully I can get a little more time on my desk. But thank you for having me. I love what you're doing.
Thank you. Bye. Likewise. Back at